بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي إخواني أبنائي الطلبة، يتجدد بنا اللقاء مرة أخرى في محاضرة جديدة في سلسلة محاضرات Ophthalmology Made Easy، وفي إطار Continuous Medical Educations for Postgraduate Students in Ophthalmology. The lecture for today is one of the important subject, which is the different generations of IOL calculation formulas and the evolution of the IOL calculation formulas from the era of initial cataract surgery, from the intracapsular to the phacoemulsification surgery. And this subject is very important because the huge evolution in the accurate prediction of the IOL calculation formula comes concurrently with the evolution in the techniques of phacoemulsification, also in the evolution of the manufacturing of the intraocular lenses and the evolution in the premium lenses IOLs, and also the elevation of the expectation of patients for having a very accurate result after cataract surgery. And as you know, for a successful cataract surgery, you need a very sophisticated and very advanced and safe phaco machines, as well as much improvement in the skills of the surgeons, and this should be concurrently with an accurate prediction of the post-operative refraction for patients. So the evolution of IOL calculation formats should be going parallel with these evolutions in the different techniques in the evolution of the phaco machines, as well as the evolution in the biometry machines that's measuring the axial length of the eye, and the evolution in the IOL manufacturing techniques and the strategy. So today we will speak about the different generations and the evolution of IOL calculation formulas, including the integration of the artificial intelligence in the future IOL calculation formulas, as well as the toric calculations and the accurate prediction for the post-operative result after IOL implantation. So we will start, and I hope that you will get benefited from these lectures, and all the links and websites is available at the end of this lecture, and you are welcome for any discussion or any verifications, and I hope that you will enjoy this lecture. By the outline of this lecture, we will discuss a brief introduction about the history of IOL calculation, and we will give the underlying principles for the different generation of IOL in the form of historical and refraction-based formula, and the theoretical formula, and the regression formula, and the versions formula, and the retracing. Now, the rest of these items will be discussed in the second lecture. So we will discuss only these subject in this lecture, and the remaining will be discussed in the second lecture. In an introduction to the science of biometry, which is just simply applying the science of mathematics to a biological tissue. And in ophthalmology, we use this term to calculate the power of the intraocular lens that needed to achieve post-operative metropia. And here we should not forget the first intraocular lens implantation done by Dr. Harold Ridley at 1949. And unfortunately, it ended up by a refractive surprise of 20 diopters, and for this he get a prize from the Royal College. And after that, doctors start thinking of doing a preoperative calculation of the intraocular lens needed for the patients. The most famous one is then the one done by Dr. Vedorov, who is a Russian doctor, and he's a politician, that he made the first equations for the IOL power calculations. So from this, we can understand that the process of IOL implantation predates the science of biometry, and also before we used to do a calculation, we do the surgery first, and then we do the glasses after the surgery. Now in the recent time, we do the reverse. We do calculations of the intraocular lens first, and then we do the surgery, so that we aiming to achieve a perfect state of emmetropia after surgery. As I said before, the real beginning of the usable IOL technology occurs during the World War II, as Dr. Nicholas Ridley was on duty as he's an eye surgeon dealing with the eye casualties and eye injuries during the World War II. And he was dealing with the crashed pilots, and he observed that small pieces of the materials from the glass of these planes has entered in the eye and doesn't create any inflammations. And they discovered that this material is made up of BMMA. And during this crash, there is no inflammations or any reaction inside the eye. So he started thinking to use this materials in the construction of the intraocular lenses. In late 1940s, he met clandestinely and John Bix from Rayner Company in London, and he discussed with them the first world IOL design, and it was made or named as ICIS Transpix, were made of high quality version BMMA. And this biconvex Presbyx around 138 milligrams. Now, in November 29 of 1949, at St. Thomas Hospital in London, Ridley inserted the first lens in a 42 years old woman after an extracapsular cataract extraction. Actually, the surgery done in two stages. Initially, he did the surgery, and after that, he did the implantation of the lens after 3 months. And the post-operative result was a high degree of myopia. And Ridley continued to perform this surgery for around 750 patients in the next 10 years. So this is the beginning of the IOL implantation by Dr. Ridley. From the time of the work of the Mr. Ridley and his operation, many doctors try to think to find out a way to mathematically predict the power of the IOL needed for the patient so that he can reach to a state of ideal emmetropia after surgery. And there are, as I explained earlier, many attempts. One of the famous one is the mathematical equation made by Vedorov, who's the ophthalmologist from Russia, that he created a mathematical equation that uses certain ocular parameters to predict the effective lens position. The effective lens position is thought to be the main determinant factor that predict the state of refraction of patient after surgery. Previously, it was named as the anterior chamber depth, but this is not accurate term. And the main accurate term is the effective lens position, because the anterior chamber can describe the distance or the space between the corneal vertex and the surface of the iris. However, with the implantation of the in the bag intraocular lens, still there is some another space between the iris and the capsule. So the proper description is the effective lens position, which describe the distance between the principal plane of the IOL and the cornea or the corneal vertex. Now, Vedorov created his mathematical calculation from the Gaussian optics, which is invented by Carl Friedrich Gaussian. And this Gaussian optics describes the state of thin lens optics and thick lens optics. And he based on the paraxial optics. Paraxial optics means that he ignores the rays that is comes in the margin of the cornea beyond the optical zone, and also it deals with the light as a ray rather than as a wave. So it neglects the phenomena of dispersion and diffraction that happens in the light wave theory. So he deals with the light as a ray rather than as a wave. And the Carl Gaussian optics was preceded by the assumption of the reduced eye model that's made by the Swedish mathematician, that is Gullstrand, who gives an assumption of the shape and the principal points of the eye, the focal length and the nodal points of the eye. And based on his assumption and the use of these reduced models and the use of the real refractive indexes, Carl Friedrichs made his Gaussian principle or Gaussian optics theory. And with this work, Viderov utilizes this work, and he created his mathematical formula for measuring or the prediction of the intraocular lens power needed. Now, if you can see, this is the formula for Viderov that predicts the IOL power. It uses different variables. The main two variables is the net corneal power and the axial length as very important denominators to predict the effective lens position. And the axial length, initially it was based on the ultrasound axial length. Now the recent machines, they do calibration to adjust this axial length used by ultrasound to be used by, to use the optical axial length based on the optical biometry. We will explain this in the lecture of the optical biometry and ultrasound. And you can see also some other attempts made by Binkhorst. This is the formula for Binkhorst, which depends on different variables, including the corneal radius of curvature and the axial length, and the importance of these variables in determining the postoperative refraction state of the patients. You can see that if there is any minor error of the corneal radius of curvature by about 1 millimeter, this can create an error of 5.7 diopter of emmetropia. And any variations or error in the axial length by 1 millimeter, this can create an error of 2.7 diopter of emmetropia. And any error in the prediction of postoperative AC depth is create around 1.5 diopter of emmetropia, and so on. So all the recent formulas like the Hagas formulas or the SRKT formulas or the Pareto formula, all they are aimed to have a precise and accurate estimation of the effective lens position. This is the main determinant factor for proper calculation of the power of the IOLs. And all the recent formulas, they utilize different parameters reaching up to 7 parameters that can be measured preoperatively to have an accurate prediction of the IOL needed for the patient. The term effective lens position is used to denote the position of the lens in the eye after surgery. And initially it was named as the anterior chamber depth, which was not an accurate term because it does not exactly describe the in-the-bag implantation of the IOL. So the effective lens position specifically describes the distance between the principal plane of the IOL and the back surface of the cornea. In the initial formulas of IOL calculation, the first generation was not doing any prediction for this effective lens position, as they use a fixed value of 4 millimeter, because at that time only anterior chamber IOL was implanted and the exact location of the lens was known as in the anterior chamber. However, the attempt from the second and third and fourth generation, all they do their best to accurately predict the effective lens position, utilizing different variables and different regression analysis formulas to predict the effective lens position. So all the recent formulas now, they doing their best to precisely predict the effective lens position, utilizing different factors and different A constants and different measurements in the eye. And they have the competition in the accurate prediction of the effective lens position. To understand the importance of the effective lens position and the recent formula concentrating on the precise prediction of the effective lens position, because initially they were thinking that the axial length and the keratometry is the main source of error. However, when they postulate the principle of effective lens position, which is responsible for the main error in the prediction of IOL calculation, this effective lens position is based on many variables. One of them is the axial length and the keratometry. However, the other variables include the various measurements like the white-to-white diameters, the preoperative AC depth, and the lens thickness. And that's why you will notice that in the recent formula, they incorporate more variables for measurement before prediction the effective lens position. Also, the effective lens position is related to the IOL itself, the shape, the length, the thickness, and the angulation and the design of the IOL. Also, it is dependent on the surgeon's factor, the size of the rhexis, the mechanism of lens implantations, and the type of the lenses and the capsular bag integrity. All these variables will affect the effective lens position. So it is not only just the error in the axial length or the keratometry that's responsible for the poor prediction, but it is a multifactorial problem that need to be adjusted and optimized to achieve the best result. In the initial day of the measurement of the axial length of the eye, errors in the measurement of the axial length was the main factor incriminated in the errors in the IOL calculation and the errors in the post-operative result after surgery, as they found that 54% of the errors in the prediction of IOL power is due to the axial length errors, and K-reading errors responsible for 8%. And after that, the improvement in the measurement of the axial length by the occurrence of the immersion technique of the axial length and also the optical biometry. This has removed to a large extent the axial length and the K reading as a incriminated source of errors in the prediction of IOL. And they found that the errors in the estimation of the effective lens position is the main source of errors in the calculation of IOL power. And this is related to many factors, that this value cannot be exactly calculated before surgery, but it is an estimated value and predicted value. Also, the lack of personalization. The personalization means the A constants, that each doctor need to personalize the A constants based on his technique and based on the type of IOL and based on the surgery, so that by personalization of the A constants and other constants in the IOL formula is very important to achieve a very good predicted result. After that, as I said, with the occurrence of the optical biometry and the swept source biometry, which gives a very accurate measurement of the axial length, so the errors due to axial length measurement and K reading has been reduced to large extent, along with the occurrence of the elevation-based topography and measurement of the corneal power by OCT. So still the effective lens position is responsible to large extent to the errors in the prediction of IOL power. So according to the European Registry of Quality Outcomes, they say that the outcomes of cataract and refractive surgery, the percentage of prediction error between a plus minus 0.5 diopter after surgery reaching up to 73%. And this percentage is not acceptable or is still far away from optimum result. So an error of plus minus 0.5% is seen in 73% of the cases. So the aim and the target for recent days cataract surgery, as it is becoming a refractive surgery rather than a just removal of the cataract, to achieve 90% and more percentage within plus minus 0.5 diopter. And for these reasons, a lot and many attempts has been made to improve the calculation of the IOL and improvement in the prediction of the effective lens position. So the message that I want to send you, that it is not the axial length error, it is not the keratometric errors to a large extent in an average sized eyes that's responsible for the errors in the prediction of the IOL, but it is the errors in the prediction of the effective lens position is the main source of errors in the IOL calculation. Another variable, which is with the advancement in the keratorefractive procedures and the occurrence of LASIK and the changing the anatomy of the cornea and the ratio between the anterior surface and the posterior surface of the cornea after LASIK, was another source of error in the calculation of the power of the IOL. However, the recent formula has overcome this problem by measuring the net corneal power and the total corneal power, and a special machine like the LensStar 900, it can measures the total power of the cornea with very high accuracy, so that even these variables has been overcome to a large extent by the emergence of recent formulas to predict the effective lens position. But still, the state of perfection is not achieved yet, and still we are facing cases of refractive surprises, especially in extreme cases. When I say extreme cases, that is in special situations like a very short eye or a very long eye, but usually most of the formula are doing well in average sized eyes. Another special situations like after LASIK refractive surgery, or in cases of keratoconus or cases of post-keratoplasty, these cases still need more refinement and special care in the calculation of the IOL power, because the chance of refractive surprises after cataract surgery in these cases is very high. And that's why also now they integrate the artificial intelligence in the recent formula to overcome these problems and reach to a state of perfection to large extent, and a very high of prediction of the calculation of the power of the IOL after surgery. Now, for a successful cataract surgery and a very satisfying outcomes or results, there are different lines should be parallel to each other. The improvement in the IOL manufacturing techniques and the different designs of IOLs, and the innovations of the premium lenses and the toric lenses and the enhanced depth focus lenses. Also, the advancement in the phaco technology and the machines of phacoemulsifications and the safety of the procedures, and the improvement in the skills of the doctors to perform safe phacoemulsification and the occurrence of microincision cataract surgery. Also, the advancement in the biometry machines and the occurrence of the ocular biometry and very precise estimation and calculation of the axial length of the eye, along with the evolution in the topography machines and that measures the true power of the cornea. All these variables are very important to have a precise prediction of the post-operative result. So all these lines should be accompanied by a very precise mathematical calculation of the IOL power. So if you have a very good machine of phaco and very good surgeon and very good and nice intraocular lens, but you have poor IOL calculation formula, so the outcomes will not be satisfying for the patients and the doctors. So in one studies done, they discovered that about 35% of the major source of prediction errors in the IOL calculation is due to the poor prediction of the effective lens position. And also axial length responsible for 17% of the cases, and the keratometry responsible for 10% of the cases. So according to the registry of European registry of quality and outcome for cataract and refractive surgery, the prediction error within plus minus 0.5 diopter only found in 73% of the cases, and prediction error of up to 1 diopter is seen in 80% of the cases. So and the need for an appropriate and accurate mathematical calculation to predict the effective lens position is mandatory tools to go parallel with the advancement and the evolution in the technology of phacoemulsification and IOL manufacturing and production. Among the challenging points that faces the doctors for having a universal IOL formula that can deal with all types of eye as far as the anatomy is concerned, dealing with short eyes, long eyes, and average sized eyes, and also dealing with the different situations of the cornea, ranging from virgin cornea to a cornea that's underwent refractive surgery. And also the evolution of the keratometry from the initial onset of keratometry using the manual keratometry and the automated keratometry. And now they start using the total keratometric power instead of the anterior surface of the cornea only, and utilizing the radius of curvature of the posterior surface of the cornea to be included in the calculation of the IOL formula. So this is one of the challenging points for accurate measurement of the power of the IOL is the keratometry. And although the recent machines, including the topography and the elevation-based topography and the OCT, has a very precise estimation or calculation or measurement of the power of the cornea. Also, the use of the real index of the cornea instead of the postulated index made by the Gaussian optics, which uses the paraaxial principles that ignore the peripheral or marginal rays from the cornea. All this considered as a differential point between different IOL formulas. Also, the measurement of the axial length, the variation in the different machines using the ultrasound axial length or the optical axial length, and the conversion factor between the optical axial length and the ultrasound axial length. and some difficulties facing the optical biometry, that some cases with dense cataract cannot be measured by the optical biometry. So we need to use the immersion type of axial length measurement, and we do the conversion between axial length using the ultrasound and the conversion to the optical axial length. Also, the variations in the A constant, because this A constant is dependent on the material of IOL, dependent on the design of the IOL, dependent on the surgeon's factors, and all these factors need to be optimized for different procedure and different techniques for the surgeons. So all these variables are very detrimental in establishing a universal formula that can be used for all types of eye and have high degree of predictability for the post-operative prediction error for IOL calculation. Now we will speak about the way how we classify the different IOL calculation formulae. Usually there is main ways of classification, classification based on the generations, and the generations means the time interval taken for these formulae to be created, and the upgrade and the evolution of these formulae. The second level of classification is derivation based, which is the optical principle behind this formula. So I will give an introduction to the classification, then we will take each formula one by one. Now we come to the main bulk of this lecture, which is about the classification of the different IOL calculation formulae. And to understand this subject, we should understand the different way of classifying this formulae. When I revise the literature for the different IOL formulae that has been invented to exactly determine the effective lens position, most of the papers, they concentrate on two ways of classifying these IOL formulae. The one is the historical prospect of this formulae, how they get moving from first generation to second generation to third generations, and studying the trigger factor that make the doctors think to upgrade the IOL formula due to the problems that they have faced during the use of these formula. And the second way of classifying this formula is by the theory behind the way the formula are working. So by this way, you can understand how this formula is working, and is it dependent on the pure optics, that's the Gaussian optic principle, or the thin lens optics principle, or the ray tracing, or the use of artificial intelligence, and so on. Actually, neither of these two ways of classification is superior than the other, because to properly understand and enjoy the understanding of this formulae, you need to understand the historical background as well as the basic optics behind these formulae, how they work, so that you can be able to differentiate between the different formulae, as well as you will choose the best way that suits your practice and it fits with your facility from equipment and the type of IOLs that you are implanting. So let's dive deeply and go and see what's the different classification of this formula. Now, what's in front of me is the first generation, the historical classification, which start with the first generation. And as you can see, the first generation actually started after the innovations of IOL implantation made by Dr. Ridley at 1949. And unfortunately, after the huge refractive surprise that happened after that surgery, so the doctors start thinking how to improve and smoothen the result of IOL implantation after that surgery, and plenty of formulas has been invented, and all of them are theoretical formula. These theoretical formulae are means, when I say theoretical, it means that it is just based on mathematical calculations of the effective lens position. And as I explained before, that the main important variable that determines the power of the lens is the location, where this lens is placed inside the eye, which is known as the effective lens position. So many formulas have been invented, like the Pinkhorst formula, the Gill's formula, the Clayman formula, the Viderov formula, but the Hofer's formula and the Binkhorst and the Viderov are the most common at that time, and they are pure theoretical based on thin lens principles, based on reduced eye model, so that it deals with the eye as a thin lens, as a single optics, instead of having more than optical devices like the cornea and the lens. It deals with them as a single optical structure, and this is called a reduced eye model, and it deals with the eye as a thin lens optics. As you can learn later on, that there is another principle, which is the principle of thick lens optics, which differs than this principle, and we will discuss it later. Among the first generation formulae is the what's known as the regression formula. Now, as I said, this is a pure theoretical formula just based on mathematical calculations. However, the regression formula is retrospective post-operative assessment of the result. Now, after applying the theoretical formula, there is a predicted error of your result. The prediction error is when you subtract the manifest refraction post-operatively from the predicted measurement. The difference between these two measurements is called the prediction error. Now, if you trace back this prediction error retrospectively, this is called regression analysis. And by this way, you can adjust your measurement and you adjust your constants so that to reach to the optimum result. The famous example of this regression formula is the SRK2 formula. So this is the first level of classification. The development and the evolution and the progression of the formula continue from that time. And as the result was not satisfactory for most of the patients and for the doctors after the first generation formulas, the doctors start to modify the formulas and the regression formulas to achieve a better predicted post-operative result. And the second generation formula was modification of the first initial theoretical formula, which is the Binkhorst formula, and also the SRK to modify to SRK2 formula and the modified SRKT2 formula. So this is represent the second generations. And still, you can say that now the first generation and the second generation are obsolete now, no more used because of the poor predictability of the IOL implantation power that needs to be implanted to the patients. From that time started and after the development of phacoemulsification, and the need for precise IOL calculation is important. And because the initial first generation and second generation formula was based on a fixed variables for the anterior chamber depth, because at that time there was no posterior chamber IOL implantation, and the IOL implanted was mainly in the anterior chamber, so they presume a fixed depth for the anterior chamber around 4 millimeter, so that there is no much need for exact position of the IOL, because it is already know the place where the IOL to be implanted. However, with the advent of the posterior chamber IOL implantation and the occurrence of phacoemulsifications, the need for precise determination of the effective lens position in the posterior chamber and determine that location is very important, because it is a very detrimental factor in determining the emmetropia of the patient after surgery. So the need for a third generation of IOL that can precisely predict the effective lens position and hence provide a very limited or minimum prediction error after surgery. So the Holiday formula appears, and Hofer's formula and SRKT formula. This formula based mainly on two variables. That's the axial length and the corneal power as main dominators for the determination of the effective lens position. And also it utilizes the different innovation derivatives from the regression analysis. And these derivatives use it as a constants. For example, in the SRKT formula, they use the A constant which depend on different types of lenses and depends on the material of the lens implanted, and also depends on the procedure of the surgeons. The Holiday formula, it uses the surgeon factor, which is related to the procedure and related to the size of the rixes, and also the Hofer Q formula. It uses the different variables for the AC depth and the measurement of the AC depth and so on. So the third generation formula is more upgrade formula for the first and second generation, which is obsolete now. Now the third generation continue for decades to be used, more than 10 years to be used, and further modification has been made for the newly emerging technology and the newly emerging problems. After the third generation failed to solve some problems like the appearance of the keratorefractive procedures and the appearance of LASIK surgery and the errors that happens due to the prediction of the effective lens position. In that cases, also the appearance of some cases of keratoconus and the severe cases of corneal ectasia that make the prediction of the IOL very difficult. Also in the extremes of eye sizes, that is in short eyes and long eyes, they shows a poor prediction error. So the need for further modification of these generations needed, and we will see that in the fourth generation they have better improvement and refinement of these formulas. Now, after more than a decade of using the third generation formula, and with the concurrent advancement in the phaco technology machines and the advancement in the technique of phacoemulsification itself, with the occurrence of microincision cataract surgery and the bimanual phaco surgery, and the cataract surgery become a refractive surgery. So with the also the improvement in the biometry machines, with the occurrence of the IOL Master Zeiss 700 and the occurrence of the optical biometry using the swept source OCT and the high degree of precision of these calculations, the need for an ideal or much better IOL formula that going with the high predictability of the patient. Now the patient, they want to have an accurate measurement of the IOL. They cannot accept a post-operative refraction of more than 0.5 diopter for any reason. So the need for a very highly accurate IOL formula that accurately predict the effective lens position becomes a necessity by all doctors. And now the fourth generation is going on, which is the top most is the Holiday 2 formula and the Hages formula, the Olsen formula, the Barrett and the Barrett Universal 2, and the Evo formula and the Hofer H5 formula. All these belong to the fourth generation. And now these IOL formula are widely used over a large extent by doctors in different parts in the world. And many of them are already installed in the biometry machines like in the IOL Master 700. Now the next generation, which is still going on, but still under further assessment and evaluation, which is the fifth generation, which is utilizing the artificial intelligence in the prediction of the effective lens position. Now, as you can, or as you know, the use or the applications of artificial intelligence in the field of ophthalmology has gained a large acceptance, especially after the initial promising results that has came. And doctors start thinking, why not to use the artificial intelligence in the prediction of effective lens position, especially when there is more than one variable affecting the net power of the IOL that needed by the patients. So the occurrence of the Hofer QST formula and the LADA Super formula and the Hill RPF and the Kane formula are examples of formulae that's using or utilizing the artificial intelligence. What I want to remind you that all these formulas are for standard, spherical lenses. Now, for the subject of toric IOLs and the IOL formula for predicting the toric IOL power, this is another subject. I will speak about it later or separately, but this is the generations of IOL formula that is for spherical type of lenses, Now, after finishing speaking about the classification of IOL formulae based on the generations, now we will speak about the derivation-based classification. And by derivation, we mean the principle behind this formula. So let's go and see. Now, when we look to the classification of the IOL calculation formula based on the derivation, by derivation means based on the principle behind this formula. As I said before, the historical, or also named the refraction-based formula, which is abandoned now, is mainly based on the preoperative refraction of the patients. And of course, it gives a very unsatisfactory result and refractive surprises after the surgery. Another type of formula, which is called the pure regression formulae, which is based on the retrospective analysis of the post-operative results and modify the formula based on the result post-operatively. These two types of formula is also obsolete now by the emergence of the third and fourth generation formulae, which is based on Vergen's formula. That is the theoretical formula. Most of the third and fourth generation are theoretical formula with and without a regression analysis, so that it utilizes the Gaussian optics of the thin and thick lens principles and paraxial optics, so that it can modify the results based on certain constants, which can be 2 variables or 3 variables or 5 variables or even 7 variables. The classical example is the SRKT formula and the Holiday and the Hagel's and the Barrett Universal and the Holiday 2. These are a combination of third and fourth generation, which is based on a Vergen's formula, based on a Gaussian optics, based on paraxial optics, and also supported by regression analysis. Now, the other type of formulae, which is based on the ray tracing, some classify them as a fifth generations, and sometimes included in the fourth generations, because it is based on a special principle, which is dealing with the light as a wave rays rather than a single ray, and it extend the assessment beyond the paraxial optics to involve the whole lens or the whole cornea as a whole. So it involves all the rays from the marginal and the peripheral rays. So it provides a new concept of the C constant, which is related to the IOL in the back. The classical example is the Olsen formula, which is based on the thick lens principle. Other type of formula, which is the recent one, which is still not yet published, but it is gaining a lot of acceptance among doctors, as the initial results are very satisfying to the patients and doctors. Those formula which depended on the artificial intelligence. And the integration of the artificial intelligence is one type of deep learning and the establishment of neural network. I will explain this in a separate lecture. And the classical example is the Hill RBF formula and the Kane formula and the Ladas formula. So generally, the first generations is obsolete now, which include the historical and the pure regression formula. And the third and fourth generations now, the fourth generation is replacing the third generation, gaining popularity over the last 1 decade. And now we are in the era of the fifth generations and the evolution of the artificial intelligence formula. You can see that there is a huge international efforts cross borders to create formulas and website calculators to determine the accurate effective lens position, and more than 22 formulas are available, and I might miss also some of them. And this indicate the need for accurate prediction of the IOL power for the improvement of the quality of the life of the patient. Because if you do a successful phacoemulsification technique with a very expensive phaco machine and expensive operating microscope and with a high skills by the surgeons, but unfortunately with poor prediction of the IOL power, you will end up by unsatisfied patients and unsatisfied doctors, and the result of the surgery will be regarded as disappointing. So this is very important to cope with the concurrent improvement and the evolution in the technology, in the phaco machines, in the biometry machines, in the technique of surgery. There should be an accurate and proper IOL calculation for better prediction of the IOL power. Now I will mention a few words about the first and second generations. and I will pay a little attention to the third generations as they are replaced by fourth generations. And I will speak more in details about the fourth generation, which is the current situations. We are now in the fourth generations. And also I will pay more attention and more detailed description of the fifth generation and sixth generation, which incorporate the ray tracing and the artificial intelligence principles and these formulas and the future prospect of this formula, especially in the view of the newly emerging IOL implantation, the premium lenses and the toric lens implantations, and also the facing the problem of post keratorefractive procedures. So we are currently in the fourth generation IOL formula, and also there are the fifth and sixth generations available, but still not well published. However, the initial results are very promising, and I think in the future will be for the integration of artificial intelligence for the accurate prediction and provide a very high quality of vision for patient using this formula. Another point that I would like to emphasize that the IOL implantation predates the occurrence of A-scan ultrasound. The first IOL implantation made by Dr. Ridley in 1949. However, the first ultrasound machine has been invented in 1970s. So the IOL implantation starts before the occurrence of A-scan ultrasound. So I will go step by step and say just a few words on the first and second generations as they are obsolete now. But just for the historical prospect, I would like to say a few words about them. After the initial surgery, which is made by Mr. Ridley at 1949, many doctors start looking for the ideal calculation formula that predicts the IOL power, especially after the huge emmetropia developed after the Dr. Ridley operations. So the common IOL formula at that time was the Binkhorst formula and the Colin Bander formula and the Viderov formula and the Thygesen formula. However, the Viderov formula was the most common and famous one that was gained large popularity because most of these theoretical formulas are based on a fixed predetermined position of the IOL because at that time they were implanting only an anterior chamber IOL. So this generation of formula is obsolete now and is no more used because it is based on a fixed location of the IOL that's in the anterior chamber. Now I will speak quickly about the first and second generations, which are obsolete now and no more used. And the famous first generations formula is the Binkhorst formula and also the SRK formula by the Binkhorst formula by Dr. Binkhorst. And this formula, as you can see, depends on various parameters, including the corneal radius of curvature and the axial length, and the assumed postoperative AC depth plus the corneal thickness. That's to say, it measures the corneal depth from the anterior surface of the cornea, including the corneal thickness. As I said, that this formula is now obsolete, and you will see in the second generation that it has been modified with a Binkhorst. This is the second type of IOL calculation formula, which is made by Dr. Vidorov, who is from Russia, and he's a ophthalmologist who has many innovations in the field of ophthalmology, including the radial keratotomy. And this is his theoretical formula based on the net power of the cornea and the axial length, and the estimation of the effective lens position based on these variables. Now, after the theoretical formulas made by Vidorov and Binkhorst, it came the SRK formula, which is also a theoretical formula invented by three scientists, that's Sanders and Ritsolf and Krauf, that is named as SRK. Now, the importance of the SRK that it is at this time, the first time they introduced the principle of A constant. Although it is a first generation formula, but this A constant was not modifiable or changed by the doctors, but it was fixed variable given by the manufacturer of the IOL based on the shape and the curvature of the lens and so on. So it was a fixed value made by the manufacturer and is not subjected to variations. And that's why the SRK fall down to give a very accurate prediction of the power of the IOL, because this A constant was just a fixed variable given by the manufacturer. Why I am saying this? Because you will see that in the second generations and with the improvement of the SRK to the SRK2, now this A constant becomes a changeable and is modified based on the assumption that for short eyes the post-operative AC depth is small, and in long eyes the post-operative AC depth is large, so that they made some modification and adjustment for the A constant based on the axial length. But here, since we are speaking about the first generation formula, SRK shows better improvement as compared to the initial theoretical formula, and it is at this level it is still a theoretical formula, but the advantage that it is using an A constant given by the manufacturer, and it shows a suitable result for average sized eyes. However, it shows a under correction for short eyes and over correction for long eyes. After the emergence of phacoemulsification surgery and the posterior chamber IOL implantation and in the bag implantations, doctors found that it is mandatory to have a proper formula to measure the IOL power to be assume the new position of the IOL that's in the posterior chamber. As I said before, they were using the only anterior chamber IOL. So there is a fixed value for the anterior chamber depth and the distance of the cornea and lens. There is a fixed value. However, in the second generations, and they started planting the IOL in the bag, and by the occurrence of the phacoemulsifications, now the calculations becomes different, and they found that there is unpredictable result because of the fibrosis of the posterior capsules and the changes of the location of the IOL after surgery. So they create this second generation of formula that take in consideration what's known as an A constant. And this A constant means that not only the axial length and the cornea playing a role in the estimation of the IOL power, but also there is another variables playing in the background which contribute to large extent to the effective power position, and hence the principle of A constant develops. And you will notice that it changes between different formulas, the constants. Some concentrate on the A constant given by the manufacturer and they adjust it, and some depends on the AC depth and so on. So I will just say a few words about this second generation, provided you know that this generation also is obsolete, and this was used during the onset of phacoemulsification. The SRK2 formula is a more refinement of the SRK formula. As I said that in the SRK formula, they use an A constant which is not modifiable and dependent on the manufacturer. However, they realized that there are some other variables playing a role in the determination of the effective lens power. So they start modifying and adjusting the A constant based on the axial length. Based on the assumption that for long eyes they have large AC depth, that's to say post-operatively the distance between the cornea and the lens position due to the effect of fibrosis and the reaction and the healing process, the distance will be more between the cornea and the IOL, that's the effective lens position. And for short eyes, the effective lens position is short because of the short axial length. So based on this assumption, they start modifying and adding some correction factor for the axial length to have an optimum result for the IOL power calculations. For example, you can see here that for an axial length of 24.5, they add just 0.5 diopter to the axial length. And for axial length between 22 and 24, there is no any addition because this is the normal average sized eyes. and as the axial length increase, they increase the A constant addition. So based on this assumption, they modify the axial length to predict and have a good result, even though they do better in average size eyes, but in the extremes and the short and long eyes, they have unpredictable result. And that's why in 1996, Holiday gave an assumption that the assumption that short eyes will have small AC depth and long eyes will have long AC depth postoperatively is not a real fact all the time. And he gave a assumption of a 9 eyes model rather than a 3 eyes model. And I will explain this in the Holiday formula. But I just like to mention the importance of this assumption and its effect in the abandon of the SRK2 formula. And for that, they upgrade to the third generation and they establish the SRKT formula, which is a combination of both theoretical formula as well as a regression analysis formula. So the SRK2 formula is a regression analysis based on the result after the calculation of the power of the IOL. They determine the error that appears and they modify the A constant according to the axial length, as I said earlier. However, as I said, that this is a regression formula, but it is obsolete now and it is not used now because of the refractive surprises that happens in the extremes of the eye. So before I go to the third and fourth generations, to summarize what we have said earlier, that the first and second generations is no more used and is obsolete because the first generation is a pure theoretical formulas and the second generation is a pure regression analysis formulas. So the third and fourth generations uses the combination of both the theoretical as well as the regression analysis, and they modify the result using different variables on different constants. So the next coming slides, I will speak in more details about the third generations and the fourth generations. Come to the third generation formulae, which is commonly used nowadays, is the Hofer-Q formula and the Holiday 1 and the SRKT. And they are usually available in most of the ultrasound biometry machines. And I remember while I am in my early practice of ophthalmology, our senior doctors are used to insist for us when we do the biometry to use the SRKT formula, and we will know the principle behind each one. All of them belong to the Vergence formula using the thin lens optics and along with a regression analysis. And SRKT refers to the theoretical formula. Now, the three main types of the third generation formulas are the Hofer-Q formula and the Holiday 1 and the SRKT. And while we're discussing about this formulae, you will see that each one of them has a particular A constant, which is the, for the Hofer-Q is the pseudophakic AC depth constant, and for Holiday 1 is the Sargent factor, and for the SRKT is an A constant. These constants are important to optimize the result because these formulae are a combination of both a theoretical formula as well as regression based analysis. So to optimize the result and to achieve a better predictability, each one has a particular constant and need to be modified by the regression analysis to achieve the best result. Now, we will speak about each one of these and you will see how these constants are affecting the result of this formula. The third generation formula came after the failure of the second generations to precisely predict the power of the IOL and the estimation of the effective lens position, especially after the innovations of phacoemulsification and the emergence of the posterior chamber IOLs. And this formula utilizes main variables, the axial length and the K reading, along with other variables. For example, the A constant in the SRKT formula and the surgeon factor in the holiday formula, and the personalized AC depth in the Hofer's Q formula. So this formula shows high degree of predictability, especially after optimizing the constants, as I have mentioned, and shows high degree of improvement, especially in average sized eyes. The Hofer's Q formula, among the third generation formula. This formula invented by Kenneth Hofer in 1993, and it was mainly developed to predict the post-operative AC depth after IOL implantations. And as I said, that it is based on the axial length and the keratometric reading. And Mr. Hofer included the variable which is known as the personalized AC depth. By personalized AC depth, we mean that the prediction of the anterior chamber depth after the IOL implantations. And this prediction is initially given by the manufacturer based on the axial length, based on this equation. And this is the value given by the manufacturer. And the surgeon need to optimize and personalize this AC depth based on the measurement done after doing the operations for many patients. At least 20 to 30 cases you need to measure the predicted and observed post-operative AC depth, and accordingly you modify the personalized AC depths to reach to the better and optimum results. And this formula has been used over a wide range of axial length, and its potency mainly found in short cases, in short axial length cases of hypermetropia, and it showed absolute prediction error as compared to the other third generation formula. So it is useful in average sized eyes, but mainly in a short axis, short axial length eyes. The second type of formula, which belong to the third generation IOL formula, is the Holiday 1 formula. And this formula in 1988, invented by Jack Holiday in 1988, and it uses the same, the axial length and the keratometry as main parameters, and also he includes the anterior chamber depth, but he measured the anterior chamber depth in two steps, initially from the corneal endothelium up to the iris plan, and then from the iris plan to the anterior plan of the IOL, so that he named that portion as the surgeon's factor. And this formula found to be very useful in a wide range of axial lengths, and also in cases of large myopia or very large axial length, and cases with very steep cornea, more than 45 diopters. So the surgeon factor is peculiar to the Holiday 1 formula, and it is defined as the distance between the iris plan and the IOL plan. As I said, that the measurement of the anterior chamber depth may taken in two steps. The first step from the cornea to the anterior iris plan. The second step from the anterior surface plan to the lens or IOL plan, which is named as the surgeon factor. And this factor should be personalized. When we say personalized, it means that each surgeon, he should evaluate the cases after doing this formula and determine the error that he has find in the result, and he modify this factor so that he will reach to the best and optimum result. And you can understand that an error of 1 millimeter in the prediction of this factor can result in 1.5 diopter of changes in the refraction. So the surgeon factor is peculiar to the Holiday formula. This is the Holiday 1. We will see that in the Holiday 2, in the fourth generation, they add more variables to smoothen and verify the precision of this formula. The third type of the third generation IOL calculation formulas is the SRKT formula, which gains large popularity among doctors because of its combination of theoretical data along with regression analysis. So T stands for the theoretical, so it adopts the Gaussian optics as a versions formula and theoretical formula as along with the regression based analysis. So it is one of the most popular formula that's used over the last 25 years by doctors and gain a large popularity and still use it till now. And it has very specific advantages. We will speak about them. So this is the famous equation of the SRKT formula based on the axial length and the keratometry and the A constant. As I say, this is dependent on the IOL type and it should be customized. And here I would like to remind that when you take the measurement of your patient using the optical biometry, you should use the A constant compatible with the optical biometry. So don't use the ultrasound A constant for an optical biometry measurements. So this is important that you have to know the A constant written in the lens. Is it for an optical biometry measurement or for ultrasound measurements? And the SRKT formula, as I said, it is a combination of regression analysis along with theoretical based formula. And it is best used in average size eyes and also in long eyes more than 26 millimeter. And it assumes a new principle which is known as the corneal height. The corneal height is a factor related to the corneal curvature as well as the white diameter. And it has an offset factor that accounts for the lens prediction for the iris plan after the implantation. So the SRKT formula is still used now and it has large popularity between doctors as upgrade of the old version SRK formula. So it is one of the best famous third generation formulas so far available in the market and still present in many optical biometry and ultrasound biometry machines. So as I said that the SRKT formula is one of the most popular formula that utilizes an A constant which should be optimized by each doctor. And you can see the impact of the A constant variations on the IOL power calculation. A difference of one diopter of A constant will result in difference in the IOL power by one diopter. For example, if you can see here, if this is a posterior chamber IOL, you will use an A constant of 118.5. If it is a changer to a sulcus, you will use 117.5. If it is anterior chamber IOL, it will be 115.5. And another thing, as I said, that SRKT formula uses what's known as the corneal height. And the corneal height is measured based on the corneal curvature and the white diameter. And the distance between the iris plan to the lens, this is named as the offset factor or offset value. You will see that the same factor, this one in the Holiday formula, this is known as surgeon factor. Over in the SRKT known as the offset factor. Now, by adjusting this offset factor is very important to achieve a very high prediction for the post-operative result. And this is peculiar to the SRKT formula. That's why it is very useful in long eyes. So in conclusion, for the short term up to this level, that the Hofer Q formula is best to be used in short eyes below 22 millimeter, and the Holiday use it over a wide range between, that's the average sized eyes, and the SRKT formula is best used for high myopia and axial length more than 26 millimeter. So the Holiday formula uses the surgeon factor, the Hofer Q formula uses the personalized AC depth, and the SRKT formula uses the A constant. Now the third generation formula shows great improvement in the prediction of IOL power calculation as compared to the second generation. However, there is a little bit shortage and drawback of this formula, because this formula was based on the assumption that there is a linear relationship between the anterior chamber depth and dimensions along with the axial length. That's to say, for eyes with long axial length, the AC depth will be more, and for eyes with short axial length, the AC depth will be short. And this is not true in all the times. That's why they discovered some refractive surprises in some cases, because, for example, 80% of short eyes, they might have large lens, so, with normal anterior segment. That's to say, normal anterior chamber. And also the assumption that for a steeper cornea, you will have a deep anterior chamber. This is not true all the time. Sometimes you find a very steep cornea, but with shallow anterior chamber. So based on this assumption, there are some cases have some refractive surprises, and make the assumption made by Holiday in 1996. That's to say, there is no linear relationship between the axial length and the anterior chamber or anterior segment anatomy. And there are 9 modules of the eye that I will explain in the discussion of the Holiday 2. So this make the generation of the 4th generation formula to correct for the pitfalls that the 3rd generation has fall in. Now, after finishing talking about the 3rd generation formula, the time come for the 4th generation. After the problems that facing doctors with the advancement in the keratorefractive procedures and cases of LASIK and post-LASIK cases that need IOL calculation. Also, the occurrence of new generation of IOLs like the premium lenses, the toric lenses, the extended depth lenses, and the elevation of expectation of patients for cataract surgery. As I said before, cataract surgery becomes a cataract refractive surgery. So the need for a new generation of IOL formula that suit and solve all these problems for the patients becomes a necessity for all doctors, and that's why the 4th generation start to include more than a constant for the prediction of the effective lens position, and uses different principles. You will see that some of these formulas are versions formula, some are a combination of versions and regression formula, and some of them are using the thick lens principles like the Olsen and the Barrett and the Evo formula, and some are using the ray tracing principle. So let's dive deeply and see what's the details of this formula. Of course, there are some other formula that I don't mention here because they are less popular, like the T2 formula, which is an upgrade for the SRKT formula. Also, this is belong to the 4th generation, but it is not that famous as these formulae, so I concentrate just on this one. The first type of the 4th generation IOL formula is the Hagas formula, and this is invented by the German Dr. Hagas. I will speak a few words about this formula. During the era of 3rd generation IOL calculation formula, doctors still facing some cases with some refractive surprises, especially in the extremes. As I said before, that all formulas that were doing well during for average sized eyes. However, in extreme sized eyes, in the short eyes or long eyes, they have some refractive surprises. And the goal for doctors to have a universal formula that is valid for all eye situations, from small size, average size to large size, or the emerging of the new cases of refractive, keratorefractive cases like after LASIK, so that the IOL calculations should suit the patient's needs and expectations and avoid any surprises. So Dr. Hagas from Germany, he invented this formula which based on a 3 A constants. It is similar and close similarity to Hofer's Q formula, which uses the 2 variables in the 3rd generations. However, this formula uses 3 constants, and by adjustment and refining these 3 constants by regression analysis. By regression analysis, we means that the did the study of the cases after doing the cataract surgery and determined the post-operative error, and they refine the A constants so that they can reach to the optimum result of the post-operative expectations. So as you can see here in this, Haig's formula can cover the normal range of size eyes, and also they have what's known as Hoek adjustment for the axial length, that for short and long eyes, they did special adjustment for the axial length, for the measured axial length, so that they can suit a wide range of eye sizes. So as I said before, that the Haig's formula uses three lens constants that modify and adjust the power of the intraocular lens based on the observed postoperative results. And this constant similar to that which is used by the A constant used in the SRKT formula, and the surgeon factor used in the Holiday formula, and also the AC depth constant used in the Hoffar's Q formula. And this A constants use it based on the keratometry power and the anterior chamber depth and the axial length, so that they adjust the IOL power based on the geometry of the eye. And you can understand this, the importance of this A constant, that for example, an AC depth error by 1 millimeter, if there is an error in the measurement of the AC depth by 1 millimeter, this will affect the post-operative result by approximately 1 diopter of myopic eyes, and 1.5 diopter in immetropic eyes, and 2.5 diopter in hypermetropic eyes. So Haig's formula overcome this problem by measuring this constants, and made an adjustment for each particular variable. That's for each range of axial length there is a correction factor, for each range of keratometric reading there is a correction factor, and each range of AC depth there is a correction factor, so that it can cover a large range of eye size. Between most of the doctors, that Haig's formula is suitable over a large range of normal sized eyes, but it is very especially useful in short eyes or small eyes, as a result of many studies done that shows that the mean absolute error and the mean post-operative prediction error is very small in using the Haig's formula, and as a result it is recommended to be used in eyes with short axial length less than 22 millimeter. It is better to use this formula. Now we come to the second type of the fourth generation formulae. That's the Holiday 2, as we have finished the third generations. And we mentioned that the Holiday 1 was belonged to the third generation formulae. Now we will speak about the upgrade of the Holiday 1, that's the Holiday 2, which belong to the fourth generation formula. When we revise the history and the evolution of the IOL calculation formulas, the third generation's formulae, which was adopted at that time over a long period of time, they mainly depended on two variables. That's the axial length, which is the main source of error for determination of the effective lens position, and also the keratometry. So they were mainly dependent on two variables, that's the axial length and the keratometry. And this was misinterpretation and lead to some surprises, especially in the short and long eyes. And as a result of this, Holiday made an upgrade of the Holiday 1 formula by adding another variables. So there is another 5 variables added, so that a total of 7 variables is used in the Holiday 2. And they claim that this has led to much improvement in the calculation and the prediction of post-operative IOL power. And it was one of the first who introduced the principle of white-to-white diameter. And by the concurrent evolution of the topography machines, this was easy to measure the white-to-white diameter, because during the era of the third generation's formulae, there it is not possible at that time to measure the wide diameter because there was no machines that can measure the wide diameter. They were dependent on manual calculations. But during the evolution of the Holiday 2, the wide diameter principle was added and it was easily measured by the topography. And another innovations of the Holiday 2 formula that it convert the concept that there is a linear relationship between the axial length and the size of the eye, or the posterior segment size, or the overall size of the eye as the anterior segment as well. So there is no linear relationship between the size or the axial length of the eye and the size of the anterior segment. As I will explain later, that in one study done, there is a different classification has been done. So we have 9 models of the eye instead of 3 types. I'll explain later about them. So what are the 7 parameters that's used in Holiday 2, which is the most common is the axial length, the keratometry, the horizontal wide diameter, and the preoperative refraction, the anterior chamber depth, and the lens thickness, and also they incorporate the age. So this is the main difference between the Holiday 1 and the Holiday 2, that Holiday 1 was dependent on 2 variables, that's the axial length and the keratometry. However, the Holiday 2 incorporate another extra 5 variables can be measured by the ultrasound axial length, like the ultrasound biometry, or by topography and auto refraction. So in the Holiday 2 formula, the Dr. Holiday in 1993, he conducted a large study made up of 34,000 eyes using a 34 cataract surgeons to determine the 7 variables used in his formula and to determine the effective lens position. And as a result of this study, he came up with a new principle that is, as I said, no linear correlation between the size of the anterior segment and the size of the or the axial length. And he classified the eyes into 9 types instead of 3. Before, we used to classify the eyes as average sized eyes, or a short eyes, or long eyes. However, the relation with the anterior segment, so he can divide the eyes into 6 types based on the relation between the anterior segment and the axial length. So you might find a very large anterior segment with a very short axial length, so like in megalocornea, which you find axial hypermetropia, but at the same time you have a large anterior segment. Or you can find an average axial length with a large anterior segment that's only diagnosed as megalocornea. Or you find a large anterior segment with large axial length, so that is with axial myopia. Similarly, you can find a very small anterior segment that is known as nanophthalmus along with short axial length, or you find a small anterior segment with long or axial myopia, which is known as microcornea. So this new principle has been invented by Dr. Holiday, and this was a major source of refractive surprises, that they thought that the longer the axial length, the larger the anterior segment, which was not true in all of the cases, and was one of the main sources of refractive surprises. After the study that has been conducted by Dr. Holiday, and he applies the 7 parameter principles used in his calculation, he came up with the Holiday 2 formula, and he made a special calculation or software program known as the Consultant and Surgical Outcome Assessment Program, known as HIC.SOAP. And this is available in the website, and at that time it was not available in all the IOL calculation biometry. It was available only in IOL Master 500, but now it is available in most of the newly emerging IOL calculation biometry, and also available in the website. So these are the main 7 parameters that is used by Holiday 2 formulas, and it's still up till now one of the most famous and most predictable IOL calculation formula that belong to the fourth generation's IOL calculation formula. After that, some studies have been conducted to demonstrate the efficacy of this formula, and they found that it is valid over a large range of eyes, that is in a short eyes and average sized axial length and the long eyes. So you can see that the Holiday formula as compared to the Higgins formulas or the SRKT, they found that the Holiday formula is very accurate in almost large range of eyes, and it receives a large adoption by most of the doctors. Up till now, they are using the Holiday 2 formula. Third type of the fourth generation formula is the Olsen formula, and some doctors they prefer to make it in the belong to the fifth generation because it adopt a new principle of estimating the effective lens position using the ray tracing theory. By adopting the ray tracing theory, it deals with the eye as a thick lens principle, and it takes in consideration all the rays that passes through the cornea and converge to inside the eye. The previous IOL calculation formulas was based on a thin lens principles and the paraaxial optics that deals only with the rays passing through the central part of the cornea and neglecting the rays passing through the periphery or the marginal. That's to avoid the effect of spherical aberrations and chromatic aberrations. However, by assuming the ray tracing principle, it deals with the whole rays with the all changes happens to the rays, including the spherical aberrations and the chromatic aberrations. And no need to fudge the effective lens plane by other constants, as this principle of ray tracing will consider all the changes that happens to this rays. And he suggests the principle of C constant, which is directly related to the lens thickness as well as the AC depth. So the C constant represent one variable for the Olsen formula, and the initial result shows very promising results, especially in over a wide range of states of the eye, including the cases of post-refractive surgery, as it utilizes the total net power of the cornea. By utilizing the total net power of the cornea, no need to fudge the effective lens plan, because this is the true net power of the cornea rather than the estimation of the anterior and posterior power of the cornea. Earlier that the Olsen formula adopt the new principle of ray tracing, and by this method of estimation of the effective lens position, it became very effective and very useful in short eyes, long eyes, and also with eyes with keratorefractive procedures. And the principle of the C constant, which is the ratio by which the empty capsular bag will encapsulate and fix the intraocular lens. This is very unique approach because it takes in consideration the IOL position as a function of the preoperative AC depth as well as the lens thickness. However, the traditional variables like the axial length and keratometry and wide-to-wide diameters are unnecessary in this formula. So this is a great advantage for this formula, that it can predict the power of the lens, including in the extremes of eyes as well as after refractive surgery. And many studies done shows that this formula, as you can see here, is very useful over a wide range of eyes, short and long eyes, and also in post-refractive surgery. And why after refractive surgery? Because it adopts the true power of the cornea, or true net power of the cornea, because it uses the ray tracing and uses the thick lens principle, unlike the other formulas which uses the anterior surface power as well as the posterior surface power of the cornea. So this it gives you the true net power of the cornea even after keratorefractive procedures, because it can estimate the true net power of the cornea as a whole, taking into consideration both anterior and posterior surface together. So this is the big advantage of the Olsen formula. And as I said, some people they say that this is belong to the fifth generation of IOL calculation formula. In this slide, I will explain the difference between the previous formulas, which uses the paraaxial optics, from the Olsen formula, which we uses the ray tracing. Now, the previous formulas uses the principle of paraaxial, that is dealing with the only central part of the cornea as spherical part and neglecting the peripheral rays. So, for example, in the SRKT formula, it uses the keratometry as well as the axial length, and an A constant which is adjustable and modified according to the manufacturer and according to the design of the IOL. However, in the holiday formula, it uses what's known as a surgeon factor, which is the modifiable factor related to the distance between the iris and the anterior surface of the lens. However, we cannot measure the lens thickness because in this formulas, the thickness of the IOL is very thin to be measured. However, in the ray tracing formula, that's the Olsen formula, it deals with the thick lens principle because it is dealing with the ray tracing. So it deals with the whole rays that's passing through the eye. So they have a special C constant variable which measures the AC depth along with the lens thickness. Here in this slide, again, I want to emphasize about the principle of the C constant. And this is the new principle that is presumed by Olsen, that is important to predict the effective lens position. The C constant, as simple as that, it represents the physical location of the implant within the empty capsular bag. As you can see here, the implant is a little bit thin and is located within the capsular bag, which is thick. Now, the exact prediction of the location of this implant is variable, and based on this variability, the effective lens position or the effective lens power is changed. Now, with the available recent machines, we can measure the lens thickness preoperatively, and we can measure the IOL thickness postoperatively, and we have the anterior chamber depth preoperatively. So we can mathematically predict the physical location of the implant within the empty capsular bag based on this principle. The other thing that when the Dr. Olsen presumed this principle of the C constant, so you can see here that this C constant is not dependent on the axial length and not dependent on the keratometry power. And this is make this formula is very unique and very accurate in especially in the measurement of short eyes or in long eyes as well. The previous formula that's based on thin lens principle are mainly dependent on the keratometry and the axial length. However, in this principle of the C constant, it is mainly dependent on the the anterior chamber depth as well as in the lens thickness. By understanding this principle, this is the formula that is invented by Dr. Olsen to calculate the effective lens position and estimate the anterior chamber depth after surgery. So the AC depth postoperatively equal to the mean of the AC depth plus 0.12 H. H refers to the corneal height. And we explained before the meaning of the corneal height, which is related to the curvature of the cornea as well as to the white diameter. This is the corneal height, which is known as the H. Okay. And 0.33 anterior chamber depth preoperatively, and 0.3 T refer to the lens thickness, 0.1 L, that's the axial length, and so on. So this is the equation. You need not to memorize this equation, but to understand that the presumption of the Dr. Olsen is not related to the axial length too much and is not related to the K reading exactly. It is mainly dependent on the AC depth and related to the lens thickness, as you can see. Okay, so this is the equation of the Olsen, and this is they apply this equation retrospectively and establish a regression analysis for a series of data, and accordingly we can mathematically predict the location of the physical location of the implant within the capsular bag. Now, what's the recommended formula usage? The Olsen formula has been tried after many studies and has been applied for average sized eyes and small or short eyes and long eyes, and it shows a very useful, a very predictive result with high accuracy with all range of eye sizes. And in one study, they compare the different formulas like the Holiday 2 and the Hofar Q and the Oculix. Oculix is another ray tracing software that's used by Tommy, and also the Phaco Optics, which is the software for the Olsen formula. And they compared these formulas over short eyes, and they found that the Holiday has very poor predictability as compared to the Olsen formula, which very good predictability and very minimum error is seen, followed by the Oculix. So these two, based on the ray tracing, shows very high accurate result and very low mean absolute error. As you can see here, the mean absolute error is very low for Olsen, and then for Oculix, and very high for Holiday. Same thing, they compare the result with long eyes. As I said, because the average sized eyes, most of the formulae are doing well in average sized eyes. Now, the difference between the formulas in the extremes, in short and long, and especially in short eyes, because short eyes are very sensitive to the effective lens position. However, long eyes is mainly sensitive to the K reading and the axial length dependent in short lens and thin lens formulae. So the main challenge for any formula is in short eyes. So Olsen formula shows a very high accuracy predictability in short eyes. This study also done for long eyes for the same formulas, and you can see here in the extreme, the left side, the Oculix doing the best one with very minimum predicted error, and followed by the Phaco Optics, that's for the Olsen formula. However, for other formulas, you can see they show also a hyperopic surprises in the long eyes. For example, this RKT formula shows a hyperopic shift in the calculations with hyperopic surprise. So overall, Olsen formula is good in all ranges of eye sizes, average size, long, and with main advantage over other formulas in short eyes. Now we come to the one of the famous formulas, which is the belong to the fourth generation. That's the Barrett Universal, and it is named universal because Barrett proposed that the current available IOL calculation formulas are not meant to use for negative intraocular lenses. However, the Barrett universal can be used for both positive and negative lenses. Now the time came to speak on one of the most important available IOL calculation formula currently, which is the Barrett Universal formula, and its enhancement, that's the Barrett Universal 2 formula. And this formula originally published by Graham Barrett at 1980s, and initially he describes the principle behind this formula as a theoretical formula based on Gaussian optics, and it uses the thick lens principle, and it uses the paraaxial ray tracing. And when I say paraaxial ray tracing, it should not be confused with the Olsen formula, which uses the initially Olsen formula uses the paraaxial ray tracing, but later on he improved it to the exact ray tracing. Not only the paraaxial area measured, but all the rays is measured. However, in the Barrett Universal formula, it still uses the paraaxial ray tracing, but it uses the principle of thick lenses, and it provides a new principle known as the lens factor, which is related to the manufacturer and related to the A constant. I will explain about this just in the next slides. So the universal formula shows a very high degree of predictability over a wide range of situations and a wide range of eyes, and he developed what's known as the Barrett suit. The Barrett suit is a combination of more than one formula, about 5 or 6 formula that suit each situations. For example, for toric IOL calculations, for post-refractive surgery, and for any what's called Barrett RX. That's for, when you have a wrong calculation of the IOL, what you will do, whether you explant the lens or you do piggyback lens. So he has a special formula for the calculation for that error. So we will go and speak in detail about the principle of this formula, as it is one of the famous and most popular used now formula, which is known as the Barrett universal formula. As I said earlier, Dr. Graham Barrett published a paper on 1987 about the theoretical principle of the Barrett's universal formula. And he used the term universal because it can be applied for all varieties of lenses and all types of eyes, medium, short, and long eyes. And he described it in relation to the A constant. You will find here that the A constant of the lens and the manufacturer is important in this formula. And the main principle, it depends on the thick lens optic. This is very important because when he adopts the thin lens optics, he utilizes the term of the second principal plan of the lens. And based on this second principal plan of the lens, he measured the what's known as the lens factor. In the next slide, I will speak about it. So what makes this formula unique as compared to the previous formula, that it adopts the thick lens principle, unlike the other previous formulas that uses the or adopt the principle of thin lens optics. So the thick lens optics is utilized both in Olsen formula as well as in the Barrett universal formula. This is number one. Number two, also by utilizing this principle, he could also estimate the total corneal power exactly using the anterior surface of the cornea and posterior surface of the cornea, and so that he eliminate the bias that can be originated from the wrong calculation of the keratometric power of the cornea. So the initial paper was a theoretical paper and then undergoes further enhancement at 1991 and improved the universal formula. So he published the universal formula 2, which becomes more simplified to the users, and he need to just put the AC depth as well as the A constant to calculate the lens factor, and after calculating the lens factor, it will calculate the effective lens position. In the Barrett 2 formula, there is new terms are used, the secondary principal plan and the lens factor. Now, what's the secondary lens plan? The secondary lens plan constructed by extending the rays, the path of the rays that is refracted, when we track them back into the lens to the point where it meets the original path. So this is the principal plan. This is to say that this is the ray when they are passing through the lens, provided this is a thick lens principle. So the rays will go straight, and at a particular point, they will converge to meet at the focal point. So if we trace this rays back like this, once they meet the original rays, this is the point of convergence. That's the point where the rays change its direction. Now this is when we collect this rays over several points in the lens. So this is called the secondary principal plan. Now what Dr. Barrett said, that the secondary lens plan is a fixed level related to the lens design and lens manufacturer and the A constant of the lens. And if we measure the distance from the secondary principal plan to the back surface of the iris, which is should be available here. So this distance is named as the lens factor, as in this example. If you can see, this is the primary lens plan, this is the secondary lens plan. Now what's important for us is the secondary lens plan, not the primary lens plan. Now the distance between this secondary lens plan and the iris surface, this is called the lens factor. So the first stage in the Barrett formula is to calculate the lens factor. Once we calculate the lens factor, it becomes easy to calculate the effective lens position and determine the lens needed for implantations. And this lens factor is dependent on the manufacturer because it is dependent on the A constant. So this is an example of convex plano lens. This is an example of a plano convex lens, and this is an example of biconvex lens. This is the primary and secondary principal plans, and this is the iris, and this is the lens factor, that is the distance between the back surface of the iris and the secondary lens plan. So in the Barrett's universal formula, there's two terms, new terms used, is the principal, the secondary principal plan, which is unique for a thick lens optics, and what's called the lens factor, which is similar to the C factor in the Olsen formula, similar to the surgeon factor in the Holiday formula, similar to the A constant in the SRKT formula, and similar to the personalized AC depth in Hofer's formula. So each formula has its own constant that useful in the prediction of the effective lens power. Now the Barrett universal formula has been added to the IOL master, and with different variety, that, as I said, the Barrett suit that include the Barrett Universal 2 and the Barrett Toric and the Barrett True K formula, all are available in the IOL master Zeiss, indicating that it has achieved a large degree of accuracy that used in the IOL master Zeiss. And to know about the family of the Barrett suit, this is the Barrett Universal 2 formula, which is the core of the Barrett Universal formulas. And this is the Barrett True K formula, mainly for patients with post-refractive surgery. And the Barrett True K toric formula for toric calculations. And the Barrett RX formula for any post-operative errors IOL calculations. So you can use this formula to modify and adjust the error that you have achieved. Now I will speak about some of the studies that has been done regarding comparison of different IOL calculation formulas, and the famous one made by the Kane et al. At 2016, comparing different IOL formulas over a large sample of the eyes. And he concluded that the Barrett universal formula was more accurate than the traditional formulas, including the Holiday 2, and the main absolute error and the median absolute error in the Barrett universal 2 is lower as compared to the other formula as published by the Journal of Cataract and Refractive Surgery. Another paper as you can see, the result of the comparison of the seven most popular IOL calculation formulas over the whole range of eye axial length dimensions, that the universal or the Barrett universal 2 is the most accurate one, that shows 50% of the patients within a 0.25 diopter of sphere equivalent, and shows up to 80% of the patients within 0.25 to 0.5 diopter of sphere equivalent, and up to 90% of the patients up to 0.75. And the second step comes the Olsen formula. So this study shows that the Barrett Universal 2 is the most accurate among the most popular 7 IOL calculation formulas available in the market, and it shows high degree of accuracy and high degree of prediction of post-operative IOL calculation power. Now, when we compare the bias that happens in these formulae over a different range of eye sizes, short eyes, average sized eyes, and long eyes, when we say short eyes means less than 22 millimeter axial length, average size between 22.5 up to 25.5 millimeter, and long eyes more than 26 millimeter axial length. You can note that within the average sized eyes, all the formulae are doing well, and a very low or minimum amount of bias beyond the predicted value is observed. However, in short eyes, as you can see here, which is the eyes below than 22 millimeter axial length, you can notice that the Haig's formula and the Olsen formula have a little bit more hyperopic shift, more than between 25 to 0.5 diopter, and the Hofer Q formula have a myopic shift more than minus 0.25 diopter. And in the other, in long eyes here, you can notice that the Holiday formula have hyperopic shift of more than 0.6 diopter, and the Hagas WK formula shows a myopic shift of around more than 0.5 diopter sphere. So again, all the formulae within the average size, they have the good result. However, the difference in the formulae in the extremes, either in short eyes or in long eyes, axial length. Another study done by Millis et al. 2018, and he compared different formulas, including the Barrett universal formula with the Olsen, Higgins, Holiday formula, and Holiday 1, and SRKT, and Hofer Q formula, all of them over a sample of 13,000 eyes. And he concluded that the Barrett universal 2 and Olsen formulae ranked the first and the second, followed by the Higgins formula. Type of the fourth generation formulae is the Hofer H5 formula. And you might be surprising about the number 5. The 5 means that this is the fifth upgrade of the Hofer's formula. From the time of invention of the Hofer's formula at 1974, Dr. Kenneth Hofer adjusted and refined his formula 5 times till it reached now to the level of Hofer H5. But it is still belong to the fourth generation formula. As you can remember that when we discussed about the third generation formula, we spoke about the Hofer Q formula. And when we will speak about the sixth generation formulae, that one which integrate the artificial intelligence, we will speak about the Hofer QST formula, which belong to the fifth generation formulae. So the number 5 means that this is the fifth adjustment of the Hofer formula from the time being invented till now. And Dr. Hofer is the first one who uses the ultrasound to measure the axial length in biometry at 1974. And also he's the first one who implanted and he places the principle of bifocal lenses. So what's the principle behind the Hofer H5 formula? It's as simply as that. The Dr. Hofer he places the principle of 6 differences in the anatomical measurements or biometrical measurements of the eyes. That's to say that instead of using the average axial length for the whole population in the measurement, for a male patient, you need to use the mean axial length of the male population. And for a woman's, you need to use the mean axial length of a woman, and so on. And he conducted many studies to compare the different measurements among different sexes, and he found that the axial length, for example, in male is much more than the axial length in the female by an average of 0.5 millimeter. And also the cornea in the male is more flatter by 0.5 diopter as compared to the females, and the anterior chamber depth in men is more deeper by 0.13 millimeter as compared to women, and so on. So he suggested to use this 6 differences in the measurement instead of using the generalized measurements, and by this way he achieves more refinement and more accurate prediction of the effective lens position using this principle. So this is as simple as that. The main difference between the Hofer's the Q that's in the third generation and the Hofer's H5, which uses the same principle, but he invented the principle of 6 predilection and 6 differences in the measurement of the anatomical structures of the eye. Another thing peculiar to the Hofer H5 formula that is invented by Dr. Kenneth Hofer is he developed or establishes the race-dependent biometric averages. That is also he conduct the same principle based on different races. So he take the averages for example, the Africans, the Middle East, the Caucasians, the Orientals, and so on. So he's suggesting that for each race you should use his own biometric data, and you should not use a standard or universal data for the whole population, By this way, you can refine, and that's very clear and evident, especially in Asian populations or races, where the size of the eye is different than the size of the eyes, for example, for Middle East people. So he, apart from establishing a six difference in the biometric data of the eye, he also suggests for a race specific averages for the biometric data of the eye. This is the two main principles added in the Hofer H5 formula, which is available also online, and you can reach it and use it. Now let's come to the one important formula belong to the fifth generation IOL formula, that's EVO2, which stands for Immetropia Verifying Optical, invented by Dr. Tan Kuan Yu from Singapore. He's a senior ophthalmologist at Singapore, and he completed his fellowship with Professor Graham Barrett, the inventor of Barrett formula, in 2015. So let's look what's in this formula and what's its accuracy in the prediction of IOL power calculation. The another new available online formula, which is known as the EVO2 formula. This EVO stands for Immetropia Verifying Optical, and it is based on the principle of immetropization and the creation of immetropia factor. Immetropization means that the child, when born, he has hypermetropia, and this hypermetropia will be the trigger for the increased growth of the posterior segment and hence increasing the axial length from around 17.2 to around 21.5 millimercury at the age of 5. And at the same time, there's coordinate adjustment of the power of the eye by mild reduction of the cornea or nearly stationary the cornea and the lens, but the main growth of the posterior segment, so that it will, by the age of 6 years, the child will reach to the metropia. And there is a specific effective lens position factor used in this formula, and there is a prediction of the effective lens position, so that it gives high degree of accuracy when it is compared with other available formulas in the market. But similarly, after different studies done, especially by Dr. Miller, shows that this formula has a defect and shortage in the extremes of eyes, and this makes the principle of immetropization may break down in the extremes when there is long eyes or short eyes. However, with the average sized eyes, as we said before, it shows good reproducible results. Now, when you go online, you will find there are the different parameters. That's the K1, K2, and the anterior chamber depth, and the central corneal thickness, and the target refraction. And among the peculiar also to this formula, it is useful also in the post LASIK cases, in which you can feed the preoperative data before LASIK and the postoperative data after the LASIK, and accordingly you can determine the intraocular lens that's needed for that patient. I find this study one of the latest studies published at the January 2020 by Mr. Savini from Italy, and he compared a large range of IOL formulas, including the traditional formulas and as well as the new formula, and he compared the prediction error over a 0.5 diopters postoperatively, and he found that the EVO formula ranks the highest among the post-operative refraction within 0.5 diopter, reaching up to 90% of the cases. And the KAME formula comes to be the next. As I said, that this is a new published paper within 2020. And also, when he ranked them in the histogram chart and shows the prediction error over the 0.5 diopter, he found 0.25 diopter. As you can see, the new generation formulas ranks to be the first, and the traditional formulas, they are lagging behind the new generations and reaching up to 90% within 0.5 diopter, as compared to the traditional, which reach up to 80 and 70% prediction error. The EVO formula in its latest version at 2019, which is the version 2, has made the EVO formula into a different formulae, so that it made a suite of formula. That is the EVO IOL formula for standard IOLs, and EVO toric formula for toric IOLs, and EVO formula for post-LASIK ablation. And all uses the same principle of immetrobization, the Vergen's formula for thick lenses. And also the EVO utilizes a new concept of the segmented axial length, which is the true axial length. By segmented axial length, using the what's known as the Cox modification, which is abbreviated as CMAL. So it measures the axial length in using the Argo biometer, which is from Alcon. And this axial or segmented axial length measures the axial length in each segment of the eye. That's in the anterior chamber and in the lens separately and in the vitreous, based on the optical path difference, or the optical path for the each segment of the eye. And they claim that this is very accurate axial length measurement than the traditional axial length measurement. The EVO formula is integrated in the Ergo biometer made by Alcon. So this EVO formula is a suite of formula that utilizes the same principle of immetrobization, but with different tasks for traditional IOL, toric IOL, and for post-LASIK ablation cases. Now we reach to the end of the first lecture regarding the advances and the review in the IOL calculation formula. In the next lecture, we will discuss the last part, which is the fifth generation IOL formula utilizing the artificial intelligence. And we will discuss the special cases in IOL calculation in post-LASIK and in pediatric cataract and in keratoconus. I hope that you get benefit from this part, and looking forward to meet you in the next lecture. Thank you very much.